I now move to the last talk of our IC, which is a slight difference, a little step away from what we do in our daily practice. It's on artificial intelligence in predicting trauma and its severity. So over to you, Dr. Gairik. Dr. Gairik is a consultant with us at the cornea department, and he has a lot of work in AI. So just before everyone is leaving, I hope you'll found this IC useful, and if you did, please give your feedback, and if you have any questions beyond this or any suggestions on how to improve, we would be happy to have your feedback. I think they're going to be sharing an email with you all. Thank you.
Thank you.
Over to you, Gairik.
Thank you, Dr. Sharon and AIOS for the chance. So I'll be quick and brief. Majority has already been covered. So I think the burden of ocular trauma is something which is well known. There are so many factors which affect outcomes. We've spoken about the extent of injury, presence of cataract, posterior segment involvement. But what we wanted to do is, in our own center, our center being a referral center, invariably a lot of the cases are referred. And what we wanted to do is look at what are the factors which kind of can predict their outcomes in, after 1 year, after 2 years. And finally, it's important that these are medical legal aspects, and then prognosticating them is something very important in our scenario. So we did look at classical variables preoperatively, which were, known. You're of course looking at the extent of the wound, the vision, looking at RAPD, posterior segment involvement. But what I did a little differently in our database is, look at demographic profiling, and that is something which is missed in Indian context. It's important to understand that many of the patients do come, workplace injuries are workers, socioeconomic profiling is something very important. And invariably, many of these patients are referred multiple times. They go to one doctor, go to another doctor, then come finally to that. And does that affect? We know it does, but I kind of wanted to prove it at our level. So I used an AI model. You can use multiple ways of analyzing it, but what AI helps us is it helps me look at multiple time points, stratifying the risk factors, and kind of gives you a cutoff score. So, you're looking at the age, you're looking at the time, or you're looking at various factors. AI kind of gives you a star. So I looked at almost 1,324 eyes. We kind of categorized it into good or bad at 2-year outcomes. So they at least had 2-year follow-up. And these are patients over the last 10 years operated at our center with multiple surgeons, of course. And we kind of utilized a model which is known as a random forest classifier. I will not go into the details of that for want of time, but it's important to understand there are various ways of looking at AI, but the way we still do it is still, the basic steps of creating an AI algorithm still remain the same, where we are kind of putting in the data set, implementing a model, and then kind of visualizing the results. So the AI, in fact, had a very good accuracy in, kind of classifying these patients based on preoperative factors. Interestingly, of course, a male preponderance is known. That is something which Dr. Anand also spoke about. But when you're looking at pediatrics, it can be a confounder because ours is a referral center. Maybe that might be the reason. But over 40% of the injuries in the last 10 years of the 1,324 eyes tended to be pediatrics. Now, AI accuracy was good. You're looking at the area under curve. But what I wanted to kind of dwell at is the first parameter detected was, of course, pediatrics. And that is, in fact, known. You might require multiple surgeries. General anesthesia is always an issue. You don't intervene early, endophthalmitis, that plays an important role. But the second factor, what I wanted to highlight, is the fact that majority of these patients which we looked at in the last 10 years had a time to the hospital interval of 4 hours. And that's kind of important because it correlated very well with the fact that these are the patients, 70% of whom had more than 2 referrals. And that is, I think, a challenge because, see, we already know the various factors which were dealt with in the trauma. You're looking at counseling, you're looking at triaging, you're looking at intervening. But what is sometimes seldom not done adequately is that you refer the patient to the right person at the right time. And that's something very important. And that can kind of reduce the time it actually takes to get that primary intervention. So we cannot obviously change the known factors or non-modifiable factors. Cataract present being, preoperatively, we can't change that. If it's a large corneoscleral tear, we can't change that. But what we can dwell at and kind of intervene at our level, even if you're not in an institute and you're planning to refer, is talk to the referring doctor and refer at the right time. Because what AI picked up is patients who had multiple referrals tended to have worse outcomes, and that was one of the top 3 parameters detected, and that is a little worrisome, right? I mean, after so many years, there are so many centers at every district. there should be a better way of triaging and referring. So rest all in terms of how we manage has been dealt with, and this is kind of just to end off the IC in looking at our large database over the last 10 years. Thank you.
Thank you, Gairik. I know how much effort went into collecting and analyzing the data. With that, we come to the end of our instruction course, and I would like to thank all our speakers and, of course, our great audience. Thank you very much. I hope it was useful for everyone.
Can we have a photo?